So today, this is the last talk of today's session, and it deals with visual field progression. So what is visual field progression? Glaucomatous progression is almost 10 times faster than the normal rate of decay of visual function with age. So the normal rate of decay is about 0.07 decibel per year, whereas in treated glaucoma patients it's about 0.6 decibel per year, and it is much worse, 1.1 decibel per year in untreated glaucoma patients. So progression is not an exception, but the rule in glaucoma. Now, visual field progression, there is actually a blindness criteria which includes visual field as one of the criteria. This is the Indian criteria, where a visual field with a diameter of less than 10% in the better eye is part of the blindness definition. Thus, progression, it is important to remember that progression rates vary greatly among patients, and the whole thrust of detecting progression, of progression analysis, is to detect rapid progresses. This is important to preserve the visual function and quality of life of the patients. So identifying progression is much more difficult than detecting loss. There is this background of dynamic noise, and we have no uniform algorithm. The contributors to this background noise, or what we call variability, is the field and the point status, that is the deviation from normal. That is, if a point is farther away in the field, then the noise or the variability is going to be much greater than if it is in the central area. The eccentricity of the field, the patient test-taking experience. Sometimes the patients simply aren't alert enough, and then there's too much variability in their responses. The strategy chosen, the CETA or the full threshold strategy, or the fast strategies, whatever we take that. So as of now, so there is no uniform algorithm for progression detection as such, but of course there is something which is given by the manufacturers of all visual field analyzers. So the three main changes in defects are a deepening of the defect, an enlargement of the defect, and a presence of a new defect. These are the three primary guides to detecting progression, and the biggest bugbear here is long-term fluctuation. So this is particularly true for deeper defects and for more advanced glaucoma. So how do we look for progression? There are three ways to do it. We have the event analysis, the trend analysis, and then there are some new methods. The visual field progression. So the event analysis flags single events compared to a baseline, and the trend analysis shows the overall trends. Now the Humphrey automated perimeters guided progression analysis combines both. So before proceeding to progression analysis, one must ensure that a thorough clinical evaluation is done to look for the reasons for a new defect. So one must look for cataract, retinal conditions, or neurological disease. And the initial selection of the fields, that is a strategy, the 24-2 CETA strategy or full threshold, or what has been used, that also has to be looked into before you actually go into the progression analysis. And the duration between the fields. So the first two fields are taken as the baseline by the GPA. So they must necessarily be done in quick progression. So if you have one test that was done at one point, another test that was done after 6 months or 1 year, and those two are taken as a baseline, you're probably not going to get very accurate results there. Any antecedent surgery, there should be at least 1 to 3 months gap before doing the field. So all these factors, all these things have to be factored in before we actually go ahead and do the analysis, the progression analysis. So overview prints are very useful. They give you a first impression of the fields. Then it's also useful for assessing reliability indices, and it also helps in excluding inappropriate fields from the analysis. One can observe developing field loss earlier in the probability maps, and one can also pick up patients with diseases other than glaucoma, for example, neurological diseases or macular diseases, which just show up in the central area. Now this is the HFA, the GPA program, which is the current standard in the Humphrey perimeter. So you have the baseline test, the VFI trend analysis, and the event analysis for that particular day's field. And this is the GPA summary report. So selecting the correct baseline test is, as I had mentioned earlier, is very important. The HFA software is programmed to choose the oldest 2 matching exams as the baseline automatically. So both should be reliable with repeatable defects, and fields in the learning curve may need to be manually excluded. So that's important. One has to exclude them beforehand. One must also take a little bit of care to shift the baseline after any surgery. So this is also allowed in the current HFA. So if you have performed a cataract surgery, or if you have performed a trabeculectomy or glaucoma surgery, you can flag it and you can make it the new baseline in the program itself, in the HFA itself. So the initial selection of strategy determines the exams that will be included in the follow-up exam evaluations. In the latest HFA 3, the 3 CETA testing strategy, that is CETA faster, CETA fast, and CETA standard, may be freely intermixed in the Humphreys Perimeters updated GPO program. This was not there with the older programs, but this is available with the current program. If a series of baseline and follow-up examinations include both 24-2 and 30-2, GPA will analyze all tests at 24-2. This is another advantage with the current machine. And GPA is not designed for 10-2 tests, so we do not have progression analysis on the 10-2. So this is a summary report of the last 3 follow-up. So there is something called the last 3 follow-up report, in which it will show you the VFI trend analysis and the event analysis preceding the last 3 follow-ups are shown. And then there is something called a GPA full report, which is identical in format to the last 3 follow-up, but includes all the follow-up tests. So that is a very long report. Now coming to the individual aspects of the report. So the VFI is what is shown in the trend analysis. Now, what is a VFI? It was developed by Winston et al. As an intuitive assessment of visual function, and it reflects the vision-associated quality of life. A minimum goal to retain at least a VFI of 50% in the better eye during the patient's entire lifetime. It is center-weighted, that is, it corresponds with the distribution of pattern of the ganglion cells. It is less affected by cataracts and other media changes. And VFI is used to quantify the rate of progression on the GPA summary. So it's like it gives you a trend as to what is going to happen to this visual field down the line. It provides an overview of the patient's available visual field history. It is plotted to the patient's age to calculate the rate of functional change over time. So how do you interpret it? So you have the 2 baseline tests, so which document the initial visual field. Then you have the VFI plot, which is the regression analysis of the VFI values and a 2 to 5 year projection. And if you have more than 5 year fields, there is also something called a rate of change that is given. As you can see in this particular field, this is the rate of change that is given. And then you have the VFI bar, which is a graphical estimate of remaining useful vision at the current VFI value, along with a 2 to 5 year projection of the VFI regression line if the current trend continues. Then we come to the event analysis. Now the event analysis is based upon the criteria for progression used in the EMGT, the early manifest glaucoma trial, and it uses the pattern deviation plot. A single solid dot. So if you see, there are so many single solid dots here. So it is a point that is not changing. A small open triangle, so you have the open triangles, there are 4 open triangles here, are a statistically significant change, or the degree of deterioration expected at less than 5% at that time. A half filled triangle, that is, again, there are none here in this, but a half filled triangle would look like this. That is, there has been a change which has been seen in 2 consecutive tests, so it is likely progression. And a solid triangle, that is, there is 1 solid triangle here, so that shows that this deterioration has been seen in 3 consecutive tests, and this is likely progression. And then you also have something called an X. There are so many X's in here. It primarily signifies that this point was out of range for the analysis. So the X mainly occurs in field effects that were already very, very deep at baseline. So the detection of likely progression needs at least 5 fields, and the GCPA maps are not calculated for fields with mean deviation values worse than -20 decibels. Please remember that. So the pattern deviation cannot be reliably applied when very severe visual field damage is present, and that is the reason why when the field effect goes more than -20 dB, we do not get a GPA map. So what is the current recommendation? So perform 6 visual field exams in the first 2 years of follow-up, and this is for when you detect the glaucoma. And for those with advanced glaucoma, it is recommended to perform 3 monthly visual fields using appropriate strategy. So in advanced glaucoma, you may need to use the 10 degree and the macular program. And look what I had showed you in the initial slides for deeper or bigger and new defects. because there is no other way to go there. The other alternate methods that have been tried out are pointwise regression. This is a progressive program developed at the Moorfields Hospital, which was a precursor to the VFI, and the pointwise exponential regression. Now, these are things which are on the anvil. They have not yet been incorporated in the current HFA. We also have people working on machine classifying algorithms to identify glaucoma progression. Such algorithms operate by building a model from example inputs to make data-driven predictions or decisions. And a small note on the central field index, which again was developed by D. Moraz to monitor the 10-2 progression, but unfortunately this is also not incorporated in the HFA as of now. This is just research that's going on. So that's all I have to say. Thank you for your attention.
Sir, kuch more. I mean,
Ratni David, she has to give the keynote address identifying glaucoma progression. No. The talk on triple drug, fixed drug dose combination in glaucoma management. My early experience. Ratni David.
You can ask your question.
Yeah. Sir, in the meantime, can I ask something to Geeta?
Yes, sure.
We can have?
I mean,
No.
She has a question.
I have a question for Geeta.
Question answers we can have.
Yeah, please.
Okay. So, Geeta, what we will do? I mean, if 10-2 has no progression, right? No progression, a GPA, right?
Yes.
But patient is moderate to severe glaucoma.
Yes.
We can only, assess the patient with 10-2.
Yes.
So, is the overview printout in that case is only, we have to depend on that?
Yes, so one has to depend only on the overview printout because there is no other way, because the GPA will not analyze a field with a mean deviation more than minus 20 decibel, and particularly if it's a very deep and advanced glaucoma, one has to rely on serial 10-2 evaluations with the overview printout and a macular threshold program. If that is also, if there is a threat to the macula, that is threat to fixation, then one has to look even at the macular program serially on a 3-monthly basis.
No, if I have a 10-2 record with me,
yes.
say, because most our patients are having more than minus 12 or minus 15,
yes.
most of them,
yes.
right? So is the huge population there,
yes.
more than 15 or more than 18 like that?
Yes.
So if I have 10-2 overview with me,
yes.
so I have to go for the macular program also?
That depends on whether there is a threat to fixation. If there is a threat to fixation on the 10-2, then you may proceed to the macular macular field. But if you feel that there is no threat to fixation, you can just proceed. You can just continue with monitoring them with the 10-2 for that particular area, for the central field area. Yeah.
Thank you. And one more thing, that what you have mentioned that regarding the to check the progression, because now is the most important thing. We have to do more tests to know whether the glaucoma is progressing or not, and yes. OCT cannot detect the progression. So we have, and OCT cannot detect what glaucoma severity stages are. So we have to depend on visual field only. So in that case, there is a new, understanding that what we thought previously, that 3 tests per year, that is the most dependable and the most important way to understand progression. They say no. Now the thing is, annual visual field testing, even if you do for 2 years, that in the 3rd year can give you the understanding of how much progression is there. This is a new concept.
Yeah, so that is absolutely the bare minimum, because the context of 3 fields per year, it came in the context of the GPA report. Because the GPA report requires about 5
that is
fields
in essential perimetry. What
yes.
is the last one, the 5th one?
Yes.
We have seen that.
Yes.
But I have just presented one case, and then I can't remember that in which protocol it is. But they have seen that it's not all the time that giving you the progression. So if you do even 6 months, every 6 months, if you can follow that patient, that can be done.
Yeah, so every 6 months, but you will need a minimum of 5 fields, so you will not be able to pick up on the GPA summary report, that will not be able to give you an output at the end of 2 years reliably. You will have to wait for the third year. However, in the first 2 years, if you can manage about 5 fields at various intervals, the GPA summary might be able to help you. That's just in the context of the HFA output. Of course, it's not always practical or feasible for patients or for clinicians to get frequent field testing done from patients. It's a big inconvenience in the clinic and for patients to get frequent field testing done. It's expensive. Not patients don't like to do fields, but the bare minimum would be 6 monthly field, absolute bare minimum. But as far as using it for the GPA program is concerned, you would require a minimum of 5 fields. So yeah, so you would probably have to wait longer before you can apply the program. But yes, you could make a reasonable interpretation with 4 fields also if you have it, 3 or 4 fields. But again, the baseline, you need 2 for the baseline. And now there are some new concepts coming in with the help because now you have the CETA faster, which reduces the testing time much more than the CETA standard. So there is a new concept that is coming in of front loading with the field. So there is this Jackpoo and Michael Kalyantis, they have published in which they have made patients do 6 to 7 fields on the same day just to get them to familiarize with the field testing. Of course, that this was a research paper, so I don't know how far it is practical, but yes, it's better to familiarize people with the fields as much as possible. And
the most important part is, forget about 10-1, what is the residual field? The most important part is the residual field. What is the residual field the patient is having? The entire 10-2 is almost normal. That is a different situation. And only a small residual field is there. Then how to protect that? Because we can't see for progression, there should be 0 progression to protect it. Then the macular program comes into a role. Because all the macular program is nothing but 10-2. 10-2, the central 16 points of 10-2 is the macular program. If all the remaining peripheral points are absolute scotomas, what is the need to test the absolute scotoma? So you see what are the absolute scotomas in 10-2. And the peripheral almost 3 circles are absolute scotomas. There is no need to test 10-2. You can straight away go for macular program. The most important part is what is the residual field the patient is having. And our aim is to stop the progression and keep that residual field intact.
Yes. So, one more point, sir. Sorry. Okay.
Yes, please come. You can use the mic here for the questions.
No. Which one?
How many of you dilate the patient before visual field testing? I mean, without dilating or with dilating? Because it's a very wrong concept that some people, they always dilate the patient before visual field testing.
Normally we don't dilate.
Yeah, so that's what I'm saying, sir. It's a very, I have seen that many people, they dilate the patient before visual field testing.
No, if the dilatation
unless and until very small pupil, right? Though patient are using pilocarpine for a long time, in that case perhaps you can do.
Sometimes when the patient is having cataract, sometimes we tend to put the dilate drops. But normally we don't dilate to do the visual field. Suppose if the dilatation and cataract is there, then you consider the pattern plot.
Sir, how much change in the macular program, how much change in the decibels do you think that suggestive of progression? Like patient has done one macular program in the previous visit.
No, actually, I told you what is the residual, the field the patient is having. Now the patient is having a very good retinal sensitivity, the residual field 30 dB is having. Then okay, you can say 2 dB, 3 dB. Normally 1 dB, 1.5 dB per year is accepted. More than that, okay. But the residual field is very small. I say that even 1 dB, we should be careful. And that is your aim is to protect. Then you can take the help of OCT. Now the OCT, understanding of OCT, the GCA thickness, what is the GCA thickness of that residual? If the GCA thickness may be 70, and maybe 60. So 62 fall very, very serious. 72, okay, it's 68. 2 micron thickness fall is okay. The most important thing is the GCA thickness 70 is a normal field, 65 is a normal field, 60 is a normal field. Even though they are red, the red GCA thickness starts from 68. Still the field is normal. 65, though red, the field is normal. And the field becomes abnormal from 55 to 45. 55 to 45, absolute scotoma. Sometimes we see absolute scotoma at 55. In some cases, 55 normal. Then what is the reason for it? For many times, I thought that may be wrong. This is the recording of the OCT is normal, may be wrong. But most important thing is in the RNFL calculation circle, RNFL clock hour, right eye 11 o'clock to 7 o'clock, left eye 1 o'clock to 5 o'clock. The macular segments sectors represent. So macular sectors, take for example right eye from 11 o'clock to 7 o'clock, even though GCA thickness is reduced greater extent, and if the RNFL is having good thickness, then the retinal, even the GCA is 55, will have a normal this thing. So whenever you see advanced glaucoma, GCA is 55, you concentrate on the clock hour. If the clock hour is having good RNFL thickness, that means we are safe. Even up to 50 also the patient can. If the RNFL thickness is low, with 55 GCA thickness, it is a bad prognosis.
Sir, if I may add, sir, to what he asked.
One point,
Yes.
and again, you go for OCTA. If the OCTA is having a good peripapillary, radial peripapillary capillaries, that is also a good prognostic sign. A good radial peripapillary zone with good RNFL, even the GCA 55 or even sometimes 48, the visual field is normal. But they are going to be past progressive. In no time it will become progressive and absolute.
Yeah.
Therefore, it is a very dangerous situation. A 10-2, normal 10-2 with ganglion cell thickness 55, with bad RNFL clock hours, and OCTA with not good perfusion, in no time they will become absolute.
Yeah. Sir, if I may answer the question on the macula. So what you were asking about following up the macular program, how do you do it? So there are 16 points. So you do the macular program and you follow up and you do it every 3 monthly because it's an advanced glaucoma patient. You have to follow on a 3 monthly basis. So there are going to be fluctuations, what I have shown you, particularly in advanced glaucoma patients. So the only way to determine whether a decrease is actually real and not a fluctuation is to repeat it. So if you think there has been a significant decrease in decibel wise, dB wise, so it may be a good idea to repeat it within a week. And if you find that with the next week when you are doing it, it comes back to normal, then you can just hold on. And if you think it is still low, then you have to keep the patient under closer follow-up. And what sir was telling about the macular, what you call OCT. So the macular OCT floors, the macular OCT, the RNFL floors before the macular OCT. So the RNFL will, in advanced glaucoma cases, particularly moderate glaucoma cases, the RNFL will floor earlier, but the macular OCT may give you some useful interpretation for a little while longer. So that may be a little more useful. But in advanced glaucomas, everything has to be taken in the context of fluctuation also, because even the OCT has a 5 micron variability. Yes, it has a 5 micron variability, and the HFA also will suffer from long-term fluctuations. So the only way to determine it is by repeating the testing, and on repeat scans, if whatever you have observed is repeatable, then you know you are seeing a progression and not a fluctuation. 2 decibel, 3 decibel. There is absolutely no guideline given by anybody. You can read as many papers, Johnson and Spry, Hoda, Parrish, anybody. There is no fixed criteria on what constitutes a resolution or a point beyond which you say this is progression. There is absolutely, particularly for advanced glaucoma, there are no such set guidelines as of now. So 10-2 overview print and macular program, and you just have to look at it. The macular program has only 16 points. That's it, so it's easier to see. 10-2 has so many more points, so you have to look a little more carefully. And it has to be repeatable then you know that, yeah.
Even a single open triangle,
Yes, sir.
is the indication of progression?
So it is flagged as likely progression. It is called likely progression because it means that this deterioration has been seen on 2 consecutive tests. Now, if you look at the criteria, if you see that the mean deviation has also dropped, particularly you've been doing the fields for 3 times. You've done, say, at January, you have done in March, you've done in June, and you see that when the June field is showing you this open triangle, and you see the mean deviation also has dropped, more likely there is a progression happening, sir. But please remember, particularly when we look at the macular OCTs and the macular scans, cataract is one more reason why there will be sometimes there will be a decrease in the sensitivity. So ruling out particularly the macular GCC, the ganglion cell analysis. If there's a cataract, the ganglion cell analysis report that you get, particularly on the serous HD OCT, will be worse. Your RNFL will be better, GCC will be worse. So that means there's a cataract there because there's a media opacity which is obscuring the quality of your scan. As the same thing even will show up on the visual field analysis. So please be sure to rule out a cataract in that situation.
Do all the OCTs have the same parameters
So,
or different makes?
Almost all of them now have a ganglion cell program.
No,
Same
different,
parameter.
yeah, definitely it's a different, you have to understand the different machines
Yeah,
have
so
different.
they are not interchangeable is what if you're asking. So
they
if
are
you
not interchangeable.
Yeah, so if you're seeing a spectralis, your patient comes to you with a spectralis OCT and then you have a serous HD OCT and you want to compare the thickness of the spectralis to the serous, no, that is not possible. So they are not interchangeable, sir. Yeah, that's what.
Regarding the triangle, open triangle, half triangle and complete block, why that came into existence? Because the black square, p-value less than 0.5%, any loss more than 8 dB is a black square. So you cannot assess progression once a black square comes. So we want to evaluate that black square at that area, whether it is deteriorated twice or deteriorated once or deteriorated 3 times. For that purpose, because it is actually analysis of the black square. That is the reason why the triangle, full triangle, half triangle, complete block that came into existence.
Just wanted to ask, how do we define split fixation on fields?
How do you define split fixation? What is split fixation?
We use the term split fixation.
Yeah.
The
Yeah.
central fixation is
Yes,
involved.
what is split fixation? So you have 0 decibels in the one part of the field, and the other part of the field it is what you call, it is maintained.
So we will define it on 10-2.
No, you have to do a macular threshold. 10-2, yes, but you can confirm it using a macular field, because macular field will tell you for certain. Because if it is actually come down to 0 at that level, because macular field is at 1 degree, what you call points, and 10-2 is 2 degree differences. So a macular program will certainly confirm it if there is a split fixation.
Like 2
Yeah.
out of the 4 points.
Yes,
are
yes,
involved.
2 out of the 4 points, yeah.
Out of contest, how many of you have seen total washout after surgery with macular split?
Total washout after surgery due to in a case of macular split. Yes, so that is again a very it's a very interesting debate among glaucoma specialists. So there is a big division here. One half say there is washout, and the other half say washout is a myth. So, you know, I have not seen any washout in any of my patients following trabeculectomy or glaucoma surgery. But yes, there are some, many people attribute the so-called washout to hypotonic maculopathy. So they say the hypotonic maculopathy that happens due to overfiltration, that may be causing the so-called washout, and as it recovers, patients may recover vision as well. So yeah, that is a raging, you know, there are two different schools of thought there.
There are many papers are there regarding the washout. I mean, some they have the opinion that it was the very old concept, because that time there was not good instruments or something like that, and could be surgical problem. But the problem is, even though they have found some washout thing, and that's why they cautioned that you can just make people, your patient aware that there is a possibility. Those who are really, I mean, very visual field is very narrow. In that case, you can caution. But I think sir is there. He had many surgeries, so he could answer that.
Yes.
How many? Sir,
Yeah.
RR is there.
Dr. Ramakrishnan, sir.
Dr. Ramakrishnan is there.
Sir, about
So-
washout.
Yeah, sir,
Washout
only
in
he could
glaucoma.
answer how many washout he has seen.
Thank you. I agree with all of you, but as a senior person like Reddy, you know, I have seen few cases only, not many, maybe about 4 or 5 in my practice for the last 30 years of glaucoma. When you will get to washout, it's very, very, very advanced case of more than 0.9 cup with a very small field, or even with, mostly with temporal island of vision. A central field, everything is gone, only temporal, inferior temporal island of vision is there. In that case, of course, if you are doing surgery, you know, then chance of washout is very there, is there. And also most of the time only 3 cases of patient is not able to recover the vision. One patient partly recovered, yes. But it's very, very rare, I should mention.
So that means, sir, it is rare, but it happens. Because it happens in your hand, that means it exists. I mean, the concept exists.
Yeah, it's there, but in a very advanced glaucoma.
Yeah.
Yes.
Actually, recently we analyzed cases, 100 cases of advanced glaucoma,
Yeah.
for which trabeculectomy was done, so over a period of 1 year, and we found only 1 case which showed wipeout. So it's not very common, and if there is an indication, we should operate such patients to preserve the
Right.
visual fields.
Yes,
That is actually more dangerous, I feel.
you mean after complete surgery?
Cataract, advanced glaucoma, the small field. And
Oh, yes, yeah. Some people, know, they will go for some sort of subclinical macular edema following cataract surgery. In that case, following combined or even with trabeculectomy. So that's why you will get delayed recovery of vision in some cases. Initially, the patient will have very HM or 1/60 or 2/60. In due course of time with the steroids and other NSAID, the vision will slowly it will recover. And some 3 cases I told you, completely there was no recovery at all. So almost a total cup. Yes.
during phaco surgery also better to keep the IOP levels not going high.
Definitely, yes, sir. Yeah.
That
yes,
is
sir.
one most important.
Yeah, yes.
But we are always afraid of the wipe-up phenomena,
Yeah.
but it is not occurring.
Yeah. We talked a lot about that, but
We are always
very
afraid,
difficult
sir.
to predict who is going to develop. But
Sir, even
of course, we should be very careful.
Actually, for that, sir, the OCT with the maculopapular bundle, if the OCT is showing good thickness, 70 and 80,
Okay.
after acquiring this knowledge, I am now confidently going for
Yes,
trabeculectomy.
that's a good point. Yes, yeah. Yes.
I'm confident.
You have your evidence.
We know, I know, I got evidence.
Yes,
The
yes,
macula, the
yes.
maculopapular bundle is having 70 microns thickness.
We don't have that facility.
We need not get worried.
Yes, we have to depend
So
on
regarding
fantastic-
phaco in patients with advanced cataract, even during phaco the intraocular pressure can go up to 70 millimeters of mercury, they say, because of the fluid dynamics.
Because any
So
acute...
that is also again one risk factor.
Yes, yes, a sudden acute rise in
Yeah,
intraocular
sudden
pressure.
rise in
But
pressures.
that's very transient. Post-operatively, we should be little
We
careful.
should control the intraocular
Yes,
pressure very
yes.
much.
Thank you, sir.
Thank you. Nice session. We learned a lot. Thank you very much.